All right, so let's pay attention to how did the density change. Because when the lung is abnormal, the density changes. And normal lung is radiolucent. If we look here, it's radiolucent. It's radiolucent. It's radiolucent because the lung is a big sponge. It's like a big sponge. It's full of air. But there's still soft tissue there. There's blood vessels, there's lymphatics, there's bronchi. So there's still soft tissue there. But the ratio, which we've been talking about since day one, the ratio of air versus the soft tissue of the lung obviously has to be very heavily skewed in favor of air, or the lung wouldn't look radiolucent on an x-ray, would it? So it has to be very strongly skewed in favor of air. So when the lung becomes pathological, the ratio changes. The ratio of how much air versus how much soft tissue. So if the lung becomes opaque, as it did on those first two, one's an adult, one's a child, did the density change?
Mm-hmm.
Okay. So we know then it's an abnormal lung, isn't it? Because the density changed. Which way did the density go? Is the lung hyperlucent? Is it more radiolucent?
No.
Or did it move toward water density?
Water density.
It moved toward water density. So our ratio of air versus soft tissue, swung which way?
Towards soft tissue.
Toward soft tissue. Which means we must have less of what? Less air. Now we can have less air by filling up the air spaces. We can have less air by sucking the air out of it, which is removal. Or we can have thickening of the soft tissue. Couldn't we have more soft tissue? Yeah. That's basically what happens to the lung. That's really it. The density changes. Now, sometimes you can actually have more air in there than should be. So if we've got air, soft tissue, if you have even more air, then the lung has to become what?
Radiolucent.
Radiolucent. It becomes hyperlucent. That's what emphysema does. It packs more air into the lung. They're turbocharged. They get more air in their lungs than they know what to do with, and they can't do anything with it because they can't exhale it. That's the problem. So the lung moved to water density. In the initial assessment, is that a unilateral, localized water density?
Yes.
Listen to what the word said. Unilateral, localized, water density.
Mm-hmm.
It is localized to the upper right lung field. And we've been talking about this. The initial assessment is very generalized. We didn't say, oh, it's in segment 1 and 2. We just said it's in the upper right lung field. Would you say the density is homogeneous?
Yeah.
Now, does everybody understand what that means? What does homo mean?
Same.
Same, one. Hetero?
Different.
Multiple, different. So this is homogeneous water, isn't it? Liver. It's just water. It's water density. Heart's water. Now it's muscle and liquid, but the beam sees that all the same, doesn't it? The beam sees liquid and muscle as the same density. That looks like this and this, doesn't it? I don't see any lucency mixed in with here. Now it's not as bright up here because what? Well, isn't the lung thinner up there? Doesn't the lung go like this as you go up to the top? So it's thinner there than it is here, isn't it? Yeah. So we go up like this and it's thinner. So it's not as dense up here. But I don't see any lucency in there. This extends from the chest wall where it silhouettes to the mediastinum where it silhouettes, and in particular, where's the ascending aorta? Isn't there supposed to be a heart border and an ascending aorta? Because isn't there supposed to be 2 bumps on the right side, 2 convex borders on the right side?
Yeah.
Yeah. Where's the convex border on the right side that's supposed to be medial to the hilus right in here? Can you see it?
No.
No. Why not?
Silhouette sign.
Silhouette sign. So it goes from the chest wall to the mediastinum, silhouettes the ascending aorta, and from the apex, terminating at a horizontal, well-defined line in the mid-right lung field at the level of the right lung hilus. Do we have a normal border in the lung right there?
Mhm.
What is it?
Minor fissure.
Minor fissure. Is the minor fissure normally positioned?
Yes.
Yeah. So if the minor fissure is normally positioned, did the overall physical volume of that part of the lung change? Did the actual physical volume, the amount of space that the lung is taking up there, did that change? No. And how do we know? Because the fissure didn't go anywhere. Now, the fissure could only go one of two places. It can either go this way or it can go this way. It can go up or down. Didn't go this way, it didn't go this way, because that's about where the fissure should be. So the fissure didn't move, which means the physical volume of this didn't change, did it? Because we can change the density, we can also change the shape, or both can happen. Both can happen. If this is homogeneous, what is it telling us about the number of acini involved? Remember the acinus?
Yeah.
It's the
All of them.
respiratory zone of the lung, everything distal to the terminal bronchioles.
It's multiple.
Hmm?
It's multiple.
Well, if it's homogeneous, wouldn't it mean basically that 100% of them are involved? Meaning, none of them can have air in them, because if some of them had air in them, then we'd get some speckled lucency in it, wouldn't we? Yeah. So it means that 100% of them have to be filled up. All of them are filled up, right? Including the bronchi. Now how did this, whatever this is, how did it spread so easily? Pores of Kohn, canals of Lambert, channels of Martin, that's how it spread. It spread very easily and very quickly. And do you see how it never crossed over? Because what's right below the minor fissure?
Visceral pleura. I mean, we have the middle lobe.
Yeah, middle lobe's right below it, isn't it? And the pleura separates the two. Do you see how this came right up to the fissure? Perfectly normal below it. Came right up to the fissure, never crossed it. Why? How come it never crossed it?
It would have to go back into the main stem bronchus.
Exactly. It can't cross over because there's nothing to let it cross over. It's like wrapping the lobe in plastic saran wrap. It isolates the lobe, and the only way is to go back to the hilus and go out in the other lobe, the other lobar bronchus, the only way. So 100% of the acini are filled up. So this, since the physical volume of the lung didn't change, is this a replacement problem, meaning replacing the air with something else, or did we just remove it and not replace it? It
Replace.
has to be replacement, doesn't it? Because if it was removal and no replacement, the volume would change. The volume would change. And the volume didn't change. So this is airspace consolidation. So is this. Much smaller patient, yeah? This is a lobar pneumonia. Lobar pneumonia. To have an entire lobe completely opacified like that is likely a pneumonia, and likely a bacterial pneumonia. And these are going to be very sick individuals.
Can you tell the difference on the radiograph between viral and bacterial?
No, you can't. Even viral can do this. It's uncommon for viral to do this. Even viral and mycoplasmal, we lump them together. But this, and clinically, these patients are going to be very sick. High fever, localized chest pain, and they just constitutionally are ill. And oftentimes bedridden, these people, because this as an adult could be running a 103, 104 fever. Which as adults, you know, you can run a half a degree fever and you just don't feel very good. Multiply that 8 times, you can hardly move your head off the pillow at 104 in an adult. Now this one could be out running around outside with a 104, but not an adult. It makes people very, very sick, and they go downhill very fast. Oftentimes they've been fighting an upper respiratory viral infection, but they go down very, very quickly. This is pneumococcal pneumonia, which is the most common acute bacterial pneumonia in humans. Great example also of airspace consolidation. Airspace consolidation. How many segments? How many segments?
Three.
How do we know?
Because it's
Where your water bottle?
The right upper lobe. The entire right upper lobe is.
Well, we know from the frontal view which segments have to be involved.
2.
1 and 3, 2.
We know that 2 has to be involved because 2 is directly above the fissure. Since it goes all the way to the apex, we know that 1 has to be involved, or apical. So we know that 1 and 2 are involved. How do we know whether 3 is involved or not?
Chest wall silhouette.
Yeah, but 2 gives you a chest wall silhouette and 1 gives you a chest wall silhouette.
Right one.
Otherwise, you
Three
would
will
have
give you a chest
some
wall silhouette.
lucency.
In the right one, are 1 and 3 the same lobe?
No.
You would have some lucency if 3 was not involved.
That's what I meant.
The point is, you can't tell without the lateral for number 3.
Okay.
But the point is, if all of 1 and all of 2 are involved, all of 3 is probably involved also, most likely. So, if we use this water bottle as an example, this water bottle is about 2/3 full of water, isn't it? We replaced the air with water, but the physical volume of the water bottle didn't change, did it? Now, if we could maybe stick a needle through the side of this and pump more water in there than this thing could hold, we might actually bulge the walls of the water bottle out, right? And sometimes that happens. If we bulge the fissure down, it would tell us that we may actually have 100% plus of whatever's filling that up. The fissure would move, but it would move away from the increased density. Now, if we empty this water bottle out, that would kind of represent the lung, wouldn't it? You'd have air inside it, and the bottle would kind of represent the soft tissue. Agreed? Mm-hmm. Now, if the top is off, I take that water bottle and squeeze it, what happens to it?
Shrinks.
It shrinks up, because what did I do? Squeezed all the air out of it. Did I change the amount of soft tissue?
No.
No. Did I change the ratio of air versus soft tissue, though?
Yeah.
Yeah, but the shape changed, didn't it?
Mm-hmm.
That's atelectasis. Atelectasis is also airspace disease. This is the water bottle full of water. That's what's called consolidation. We changed the density. We consolidated it and made it one density. And there's 5 things that do that: blood, pus, water, protein, or cells. That's what fills up airspace. Blood, pus, water, plasma fluid, protein or cells. And protein and cells are very unusual causes. Most of it's blood, pus, water, and most of that is pus and water, meaning exudate, infection, which is what this is, or pulmonary edema, which is what this one is. Okay?
Is that patient at full inspiration or no? It's kind of difficult to tell. Are they just having a hard time inspiring because of the pneumonia?
We're 10 would be about here,
Right.
and that may be as much as they could go
Okay.
with that. Yeah. Because they're going to have chest pain,
Mm-hmm.
difficulty breathing, high fever, cough.
So you would consider that a good film? You wouldn't need to retake it?
Yeah, I wouldn't redo this. Yeah, these are both.
Yeah.
Yeah, they're both adequate
Okay.
film. So this is what's called lobar pneumonia. Okay. So for atelectasis, I can squeeze this externally and squeeze the air out of it, right? I could also put my mouth over the top of this and suck on it good and hard and pull the air out of it. Would it collapse then also?
Mm-hmm.
Yeah. But see, one, I externally just squeezed it. Nothing wrong with the airway. The other one, I sucked the air out of it. But it collapsed, but for 2 different reasons. Because there's 4 causes for atelectasis that we'll talk about next month.
You said cells was the fifth one, right? Blood plus water, protein cells.
Yeah, blood, pus, water, protein cells. Protein and cells are really rare.